in treating patients with cystic fibrosis as young as 2 years. It's a great advancement that we have the drug provided in Egypt nowadays, and great thanks to Dr. Tanya. But still there are some question marks regarding its safety and efficacy. Its safety and efficacy, whether it is tested in pediatric populations, what about if Trikafta is discontinued or not available due to any reason, and the experience of patients who used the medicine. Cystic fibrosis is a genetic disorder caused by mutation in the cystic fibrosis transmembrane regulator gene, as we all know. It results in thick mucus lining the lungs and the digestive system, resulting in persistent bacterial infection, multiple organ damage. Treatment was limited in the past to just managing the symptoms, but now Trikafta and the other modulator therapies are directed towards the root cause of the disease. The triple combination therapy, elexacaftor, tezacaftor, and ivacaftor, they work in synergy in order to, they work on the defective gene in order to enhance the protein effectiveness at the cellular level. Elexacaftor and tezacaftor, we call them the corrector. They bind to different sites on the CFTR protein, stabilizing its structure and helping it to reach the cell surface. While ivacaftor is known as a potentiator, it enhances the opening of the channels in order for the chloride transport to improve. By this improved chloride ion transport, the mucus consistency normalizes in the affected organs. Let's travel through the clinical trial journey, starting from phase 1, which were small-scale studies in healthy volunteers, followed by phase 2, small-scale studies in cystic fibrosis patients. Phase 3 studies, we can call them the pre-approval studies, and they were large-scale studies after which the FDA approved the drug. Then phase 4 studies, the post-approval studies aiming to detect the real-world effectiveness and long-term safety. We will dig deeper into phase 3, trials 1 and 2, as they were the pivotal trials after which the drug was approved. Trial 1 and 2 were on 403 and 107 patients aged 12 years and above. The targeted patients in trial 1 were having either 2 homozygous deletions in the delta F508 gene or a single mutation in addition to another mutation. And the results showed a significant improvement in the percent predicted forced expiratory volume compared to placebo cases at week 4. At week 24, there was significant lung function improvement, 63% decrease in pulmonary exacerbation events, and observed body mass index increase, and a significant improvement in the quality of life as measured by cough, mucus production, and wheeze. Trial 2 targeted patients having only the homozygous mutations of the delta F508. They compared the Trikafta to the previous dual combination therapies, tezacaftor, ivacaftor. Trikafta showed a significant improvement in the peak, in the percent predicted forced expiratory volume, reduction in sweat chloride concentration, and improved quality of life as compared to the previous dual therapy. After approval of the drug, phase 3 started focusing on the pediatric age group. They focused on the safety of the drug in the tiny developing bodies, tracking their height, weight, body mass index, and the sweat chloride levels, in addition to assessing the impact on daily activities and family dynamics. In trial 3, participants were 66 children, aged 6 to 11 years old, and results showed significant improvement in lung function, from baseline. The safety profile aligned with that in the previous two studies. 62% had cough, headache, fever, nasal congestion, and they were attributed to the disease pathology, not the medication. 2% had serious adverse reactions, but they were not attributed directly to the treatment. 8% had transient elevation in liver functions. They didn't require discontinuing of the drug. 9% had rash events, were mild, self-limiting, and responsive to treatment. Our patients 6 to 11 years showed remarkable improvement in pulmonary function, dramatic decrease in sweat chloride concentrations, approaching normal levels in many patients, improvement in the quality of life and nutritional status. Trial 4 was on children 2 to 5 years old, and it showed that almost all participants experienced some adverse events. However, the adverse events were of mild intensity. Moderate intensity were only in 1/3 of them. The most common adverse effects was in the form of cough, fever, runny nose, and upper respiratory tract infection. Serious adverse events occurred in 16% of patients, and they were in the form of respiratory exacerbations, none deemed by investigators as being related to the treatment, and the treatment wasn't discontinued again. There was transient elevation in 19% of children, and the majority resolved without any intervention. Patients showed decline in sweat chloride levels up to 57.9 millimole per liter from baseline, and a stable body mass index during the 24-week study. The FDA approved the medicine for children aged 12 years and above by 2019, 6 to 11 years by 2021, and fortunately 2 to 5 years by 2022. After approval of the study, a prospective observational study was performed in order to assess the long-term impact after approval, and it showed comparable results to that of the trial results. Of course, the main impact of the drug is best measured by patients' experience. Some patients reported their ability to attend sports for the first time in their lives. With less hospitalizations, they are now able to join school and achieve better results. The most touching stories was about patients who can experience now daily activities like attending school trips. Even adolescents reported improved self-image after gaining weight and participating with their friends in their activities. A mother of a 6-year child stated, "We've seen a dramatic improvement in our child's health since starting the drug. He hasn't coughed, which he previously did for hours a day because of the thick mucus that lines his lungs." Another mom, "My child is now a healthy, thriving 5-year child. Before Trikafta, we lived in a 3-month increments between hospitalizations. Now he is on the support team. The psychological burden that's been lifted from our family cannot be overstated." We have more than 177 genes responsive to Trikafta, mutations responsive to Trikafta, covering approximately 90% of the CF population. 45% of patients are having homozygous delta F508 mutations, and these patients are strongly responsive to Trikafta. 41% have heterozygous mutation of the delta F508 gene in addition to another mutation. A very small proportion are having residual function mutation and gating mutations. The gating mutations were previously treated with ivacaftor, now benefits more from Trikafta. We've been through the dosing schedule in the morning. I'll go through the pediatric dosing 6 to 11 years old. The morning dose is in the form of 2 light orange tablets. the evening dose, 1 light blue tablet. The 2 tablets are elexacaftor, tezacaftor, and ivacaftor, and the evening dose is ivacaftor only. They must be taken with fatty food. Continuous daily treatment is important to achieve better results. Although Trikafta costs very high annually, studies indicate that the medication reduces hospitalization by 63%, decreases antibiotic usage by 44%, and cuts emergency room visits by 58% compared to standard care. Despite progress, Trikafta still faces several challenges: the medication adherence to twice daily dose, the fatty meals, the long-term unknown, and the potential for liver issues and cataracts. Monitoring is essential to avoid side effects. A baseline assessment of liver function tests, ophthalmologic examination, and baseline symptoms, followed by liver function tests every 2 months. Eye examination annually under 18 years, as children have the potential to have non-visual cataracts, and then ongoing assessment of the side effects and the symptom improvement. An important question: what if Trikafta is discontinued or not available due to any reason? Clinical studies show rapid deterioration in lung function within 2 to 4 weeks of discontinuation, increased sweat chloride within 4 weeks. Patients reported increased mucus production, cough, shortness of breath, some pulmonary exacerbations requiring hospitalization, typically after 2 months from stopping the medication. It is recommended to return to the pre-Trikafta treatment if Trikafta is not available due to any cause. We still have limited availability globally, insurance coverage gaps. The limited availability sets some countries to have a patient selection criteria. Some select younger patients, some select patients having severe disease. We're still having the 10% gap for those patients non-responsive to Trikafta, having non-responsive mutations. The highest prevalence is in USA. However, the insurance coverage, as Dr. Sania stated in the warning, the insurance coverage covers or gives the medication to all the eligible patients. In our developing countries, still we have challenges beyond the medication access. Lastly, Trikafta gives a new hope for our families, our CF families suffering from frequent hospitalization, to live a near normal life. Thank you. دكتورة نيهال بجد كانت محاضرة جميلة و to the point